Hello, I'm Mally Shansfeld, Managing Editor of Endodontic Practice US, a MedMark publication. Welcome to a live presentation and question and answer with Dr. Alan Atlas. In our webinar today, we will be exploring the spectrum of treatment protocols required for the successful restoration of the compromised endodontically treated tooth, including step-by-step protocols from post-space preparation to core and post-placement with HD video obtained with the dental microscope. Before we get started, I'd like to invite viewers to use the question box in your control panel to ask any questions, and your questions will be answered at the end of the session. Also, to receive CE credit for this presentation, you must complete a free CE quiz. Within 1 hour of the end of the webinar, we will email all attendees instructions on how to access the CE quiz and the webinar replay. I'm pleased to introduce our guest for today, Dr. Alan Atlas. Dr. Atlas maintains a full-time private practice dedicated to aesthetic and comprehensive restorative dentistry located in Philadelphia, Pennsylvania. He received his DMD degree from the University of Pennsylvania School of General Medicine and currently holds a dual appointment as clinical professor in the Department of Endodontics and the Department of Preventive Restorative Sciences. He is director of the Endodontic Restorative Microscopy and Technology Clinic at Penn Dental Medicine, teaching students precision restorative dentistry utilizing the dental microscope and digital technologies. Dr. Atlas is an internationally recognized lecturer and researcher whose unique academic and private practice perspective is focused on applying scientifically based protocols to general and advanced clinical dentistry. His presentations have been seen worldwide, including China, Africa, Australia, the Middle East, Japan, Korea, and Europe. Dr. Atlas, we turn the webinar over to you to learn more about our topic for today.
Thank you. Hello, everybody. Welcome to Endodontic Practice US webinar. It's a pleasure to be here. I want to thank Endodontic Practice for inviting me to give this unique presentation. And of course, I also want to thank Zeiss Microscopes for their contribution to my honorarium on this very valuable and educational webinar that I'm going to present today. Few disclosures, some of which I already did disclose. I do want to make sure that you know that I have no financial or personal interest in any of the products that I'm going to show today during the presentation. I show everything related to my research, and I've done research funded by these various companies. I've been principal investigator on many clinical trials. I've done many in vitro studies, and I continue to do that as part of my quest to achieve the ultimate dental practice protocols. But the important thing I want to emphasize is that everything I'm going to talk about today, everything I'm going to mention, everything I'm going to suggest and recommend is going to be supported by the dental literature, as well as products that I use personally in my practice, as well as I use during my teaching at Penn Dental. I am a research junkie. I read everything to the point where any of my spare time that I have, I go on PubMed and I see what was in my box for the day every day. It's something that I really enjoy because I really want to see what I can take from the evidence and put it into our hands and make us and allow us to do better dentistry. I think that's ultimately the goal. How can we do better dentistry to help our patients? And this is what we got into our profession for, is to help our patients become healthier. So I hope you'll see that I'm not a big anecdotal person, a research or evidence person. I really like to look into the facts. Obviously, the facts can be not as expansive as we would like, but we're going to do the best we can in order to achieve the best outcomes. So what are the objectives today? I think I'm going to try to do over the next hour is really to help you understand why we're getting failures in endodontically treated teeth. There's a lot of speculation, a lot of theory, a lot of guessing, but I'm going to nail it down via the research and show you why and what's happening. And then, of course, we're going to figure out how we can do it better. We're going to discuss risk assessments. Risk assessments are very important to understand when making the determination of you going to save a tooth or place an implant. And again, my objective as a clinical dentist, as well as a researcher and a teacher, is always to try to save the tooth first. We just can't make that decision or determination by one picture or one radiograph. But I'm going to give you some important criteria that you'll need to use in your assessments in order to make the right decision and help your patients make the right decisions. Next thing we're going to do is something that's always been a big dilemma for a lot of dentists, probably because they don't like to place a lot of posts, but I'm going to show you and help you understand when to post or not to post. We do need posts, and part of what I'm going to show you is and demonstrate today is unique post placement guidelines, core buildup, as well as post space preparation guidelines. And I think that's going to be very, very unique and important for you to do it, because if you can do it easier, you'll want to do it more often. We're going to understand how to accomplish endodontics to crown in less visits. Typically, this takes an extraordinary amount of time, making the tooth very vulnerable during the courses or during the visits between endo and restorative. What we want to try to do is secure the tooth better. I'm going to give you some unique ways to achieve that today that not only will make it better for your patient and the tooth, but will make it more profitable for you in the long term. And then, depending on who's on this presentation, I'm going to discuss effective communications with restorative referrals. If you're an endodontist looking to understand how to do better referral basis with your colleagues, I'll offer some tips, and to understand how the whole team plays a part, how we all contribute to the success of the final restoration. It's going to be very important. So when I look at this picture, the first thing comes to my mind is this is not a good day in the dental office, especially if it's your patient, and especially if you did this crown maybe a year ago, and especially if the patient's in the waiting room very upset. This is the type of thing that we see happening way too often, and we have to think about why. Why is this happening? Pardon me. So we're going to have to understand that certain things are going to have to take place in order to understand why this happened. So when I look at the preoperative radiograph, this patient came to me from Florida. This is done a year ago by her previous dentist, and we can look at this radiograph, and for all intents and purposes on the PA, the post placement within the space looks pretty good. I don't really know what's really going on here. I do see a wide cement space, which concerns me, and a little bit of an irregularity here. And then when we see what happens after the tooth fractured, we get a better understanding what's going on here. We see, in fact, post place again, good, but look at the post placement outside the root. Not very, very good. In fact, it's doing nothing to support this foundational core. And then we see the other issues with this crown. Poor fit, poor cementation, gaps. This is the big reason why we see a lot of failures in restorations. So I would say this had many, many etiologies of failure. But the bottom line is it's happening on endodontically treated teeth way too often. So we have to look and see what's happening here, because if we keep doing the same thing over and over again, expecting different results, I believe Einstein called that insanity. So what we need to do is bring some sanity to what we're doing in our operatory to avoid these issues. And I'm going to tell you by the end of 1 hour today, you will see how to avoid these issues in most instances. And again, when I try to establish why we're seeing this, I always look at the evidence. Let's see what the evidence is showing about how endodontically treated teeth are performing in the research. So this is a basically landmark study done by Rothstein and Salarabi back in 2004, and they looked at almost 1.5 million root canal teeth over 8-year follow-up. What they did is they took Delta Dental insurance databases from all 50 states. So this was not just representative of 1 or 2 states. Every state was involved in this outcome assessment. And what we see that out of the failures, if you had good endodontic procedure and a good restoration, the survival rate was 96%. And the only reasons for failure were considered because of endosurgery, which is very small, retreatment small, or extraction, in this case, was almost 3% of the time out of all of these teeth. Not a very bad outcome. In fact, unbelievably good compared to some other big type of sample size outcomes. But when we look closer to the failures, and we saw there were almost 42,000 extracted teeth with and without coronal coverage, what we see is this. Endodontically treated teeth that did not have proper coronal coverage were extracted at a 5.5 times greater rate. So if we can improve this problem right here, we can cut down the failures even greater. So there it lies. All these teeth had an issue, mostly because they weren't restored properly. First key. This is another study. This is a cross-sectional study. They looked at evaluation of related factors in the failure of endodontically treated teeth. Basically, patients presented for no general reason, either routine care or maybe had a chief complaint or some pain to Selçuk University in Turkey. And what they did is they analyzed the patient data over a 17-month period. And within that data, they found or targeted 1,000 endodontically treated teeth that had failed. They weren't sure when and how they were failed, but they knew they were failing. That data will come next. But they were referred to the department in endodontics with that very important question: should the tooth stay or should it go? So what they did find was very interesting. Out of those 1,000 teeth, 28% or 280 had to be extracted. We see that endodontic failure was not a very big part of the failure rate, as in Salarabi's study. But what we do see, 41% of these 28% extracted, or 280 teeth were extracted, which is well over 125 teeth, were due to prosthetic reasons. So prosthetic reasons was the biggest reason why these teeth were failing. And we see it happens quick. Almost 40% happened within the first 2 years. Another 24% happened 2 to 4 years after root canal treatment. Not good data for us as restorative dentists. And they concluded that the appropriate coronal restoration would improve the root canal treatment. And if it is not done well, it is more likely to fail in the future. So there we see two diverse studies, basically done in private practice. That's the beauty of both these types of studies. They were done by different dentists, different practices. It was not an academic study where perhaps the protocols were a little bit more refined and under greater control. This is a great study because we can get a flavor of what's happening truly in the trenches. And I say the trenches mean private practice. Private practice is far different doing studies in academia. And I can tell you one of the other reasons we're seeing failures, particularly, is that the E. faecalis bacteria possess these degradative activities towards dental composites, cements, increasing that biofilm that's around the surface, the interface, compromising that interface between the restoration and the tooth. So what happens is that if there's any type of roughness, irregularity at that margin, bacteria congregate, colonate, and they go to work on the margin, demineralizing it. So this could facilitate the migration of bacteria. And we know E. faecalis is one of the primary failure bacteria that we see down in failures of endodontically treated teeth. And the migration down the periradicular tissues could cause treatment failure. So there it is. We see it at a microscopic level. We see that improper coronal restoration is causing failure. It could cause caries, fracture, but also the bacteria, E. faecalis, can get down the canal and cause reinfection. So it all comes together. We're seeing how it all transpires, and it always comes down to doing a better restoration. So when I look at this case, the patient's not happy. She basically wants to go back to Florida and confront her dentist. But I told her that it's, there's a lot of variables here that, as we'll see, that will decide why these teeth fail. It wasn't just poor dentistry. Certainly it may be contributory, but we'll see there's other reasons why these things are happening. And the decisions are now, do I do endo retreatment on this case? It's going to be knee treated, crown lengthening, post and core foundation or new crown, or do I extract it and place a dental implant? And how am I going to go about making that decision? Because this is going to be critical when we do have failures, how to do that. So the big question is this bad tooth better than a good implant? And it's not a good tooth, but can we save this tooth? And again, my perspective is that I want to try to save this at any chance I can. So we know from the evidence, these are two great editorials written in the Journal of Dental Research, the highest impact factor journal in dentistry. And they look, these two guys, Ionomers and Lang. Ionomers is the head of perio at University of Michigan. Dr. Lang is a renowned researcher in Europe. These two guys came together and made some really great commentary about dental implants. Their first article is dental implants a panacea, or should we strive to save teeth? Believe me, we know periodontists like to place implants. It's transformed their profession, totally. But the question is, are we making the right decisions by taking teeth out too quick? Are we pulling the trigger too quick on teeth? Well, they found in their review that teeth compromised because of periodontal disease or endodontic problems may have actually a longevity. Can you believe that? That surpasses by far the average implant. And there are many comparative studies, systematic reviews that show this. They're listed right there at the bottom of the page. Quite surprising. And you would never hear this from the implant companies, but in fact, it's true. And when I look at this case of my patient who had that fractured tooth, well, I sent it to the periodontist and I said, hey, I want to try to save this tooth. Patient wants to try to save the tooth. Apparently it was a miscommunication between the secretary and the dentist, periodontist, and he decided to do this. Now, is that a bad outcome or a good outcome? Well, I can judge it by several factors. Every time I put the probe down this area, a mountain of or volcano of pus would come out of the sulcus. I call that an ailing implant. An ailing implant will eventually turn into a failing implant. So the dentist did not make the right decision. Not only that, he took out the tooth and did an immediate implant, didn't graft the site first, didn't put only bone graft. So if you look closely, the apices of the root are at the platform of the implant. How is the patient going to maintain and keep this clean? Nonetheless, the patient was happy with the tooth, but every time she came into my office, it upset me greatly. And I obviously my periodontist made a mistake. We all make mistakes. The only good news I have in this story is the patient moved back to Florida. So I didn't have to see that volcano of pus every time she came in. And I felt bad, but it really wasn't my fault. I did not tell the dentist to do what he did. So she'll live with it. It may pass, it may stabilize, but of course periimplantitis is setting in on this tooth immediately. And that's always going to be a concern. So when I look at another example, patient comes into your office, symptomatic, obviously lost the filling, has caries, recurrent caries. What am I going to choose? How am I going to make my decisions here? And I'm going to tell you, as any dentist, any restorative dentist, there are two critical diagnoses that you must make in order to determine if you're going to do an endo or implant in this case. First thing you need to do right off the bat, every dentist should be trained to do a pre-treatment endodontic diagnosis. That's pulpal and periradicular. And basically, you got to perform 5 basic objective tests. You got to check for pulp sensibility, hot cold sensitivity, percussion, palpation, probe. You must probe around that tooth to see if there's any periodontal issue or if we have a perioendo lesion. And then we're going to look for tooth mobility. Once I get those 5 clinical tests, I have a better sense of what's going on in this tooth. This is going to influence my decision one way or another. But there's more, because I think as dentists, we need to do the restorative diagnosis. And when we look at the restorative diagnosis, it's not just removing the decay, as totally going to be a very important part of it, but we got to look at the systemic and oral conditions. Is the patient's on bisphosphonates? As we know, we really shouldn't remove the tooth unless it's been a while they've been off of it. Are the patients on antidepressants? Albrechtsen and others have done studies where they've shown patients on high doses of antidepressants have a greater failure rate of the implant within the first year. This is not good news. So we have to be able to understand periodontally as well as systematically what the patient's doing. Certainly with patients with our smokers, not a good decision to make or place implants. What about a patient on diabetes? If it's controlled diabetes, no problem doing either. But if the patient has a high caries rate, developing decay all over their mouth consistently, has bad oral habits, bad oral hygiene, bad diet, and then we look at the occlusal scheme, the occlusal loads, and the parafunction, maybe that's not a good situation to consider saving a tooth. So you see, it's sort of a puzzle. We got to put it all together. We just can't look at this radiograph and say, it doesn't look that good. I think I'm going to take the tooth out. And I've done this. I perform many presentations where I use certain survey. I ask surveys right over there, right at the start of the presentation. I'll put up this photograph and I'll ask, what would you do? Would you take this tooth out or would you save it? And I'll tell you that depending on who I'm presenting it to, if I'm presenting it to a group of oral surgeons and periodontists, more so, I would say greater than 75% will say to take this tooth out without understanding any other criteria. Because they think, hey, I can take that tooth out, put an implant in the tooth behind it, and put 2 implants in there, and the tooth would be better off. The question, would it be? And only the person can decide, because we know an implant does not replicate a natural tooth. It just doesn't. So in my case here, the next question for my colleagues was, what happens if that was your tooth? What would you do? And there was dead silence in the audience. All I heard were crickets. And I can tell you that they were not thinking about this as if it was their own tooth. They were thinking about what's going to be the easiest, quickest, fastest, best way to make a lot of money. We can't treatment plan like that. We must give the patient the opportunity to try it and save teeth. If they can change their behaviors, this tooth can survive, no doubt. And I can tell you that when we look at bite force is one of those things that's been undervalued. I'm certainly a big proponent of determining bite force, and I'm actually working on a product right now that I think is going to change the course of how we evaluate teeth. It's something that is a novel product that's going to measure bite force in the mouth, and look for it. It's called Innobite. But I will tell you that when you look at endodontically treated teeth, they almost act like implants. Vital teeth have this protective proprioceptive feedback to biting forces. So when you bite really hard, if you bite too hard, your tooth's going to respond. That doesn't necessarily happen with endodontically treated teeth when the pulp is lost. So it's occlusal overloading causing higher incidence of fracture after endodontic treatment. I think this is one of the reasons why we have a lot of failures. So we need to look at occlusion very carefully, how this tooth is being reconstructed during the course of the procedure. So when I look at this case, the first thing I'm going to tell you is this. I need to take a Bitewing. I just can't make the decision on PA. The Bitewing is going to give me where the caries is in relationship to the osseous level. This is going to help me determine if this tooth can be saved. Now, this tooth has a nice long root. Certainly, the rest of the mouth is not great. Maybe this tooth needs a new crown, maybe need treatment. But we can put an implant here, save this tooth, probably save all these teeth, just put one implant here or a 3-unit bridge. But I will tell you, we know from the literature, 2 endodontically treated teeth as abutments for fixed partial denture, lower success rate. So my inclination is keep everything separate. And that way, if something does go wrong, then only that particular situation needs to be addressed. We don't have to remove both teeth or take off a whole bridge. Certainly single implant in this case would be the way to go. But this is what we're talking about. But I would look at all those other factors that I just talked about and make sure it can be done. So in that case, I'm going to take out and remove the caries. I did my endodontic diagnosis. Now I'm going to do my restorative diagnosis. Is this tooth savable? And I must excavate all the caries, dentin, and enamel. This is going to allow me to come up with this equation. As I know, endodontically treated teeth ideally require a minimum of 5 millimeters of tooth structure from the coronal level to the osseous level. And ideally, I would like to have about 2 millimeters, 360 degrees around circumferential of tooth structure around this canal space. Again, this is going to be very important because if I have that amount of tooth structure, the tooth's going to be much stronger. If I don't have that, as we'll see, far more compromise in the tooth. So more tooth structure, and that's why doing conservative dentistry is always going to be better, even during access for endodontically treated teeth. Again, I would like 2 millimeter height right over here, again, above that gingival complex, 2 millimeters, 360 degree height around the tooth. And this is what we call the ferrule effect. It's sort of that bracing effect against occlusal and mastificatory forces. If I have this bracing effect, the tooth's going to be much more stable during function, less likely to break or fracture. The other part of the equation, and I think for us as restorative dentists, is that 3 millimeter healthy complex. If we have caries invading this space, getting close to the osseous level, this does become a problem because we can't put the crown on top of the bone. The gum will have constant inflammation, irritation. The patient will complain about it. It will be infected constantly. There has to be a complex. And we've known this since '77 when Dr. Ingber and Dr. Rose and Koslick came out their landmark paper in the Alpha Omegan. They showed us that we need 1 millimeter connective tissue attachment, 1 millimeter junctional epithelium, and we need about 1 to 0.5 sulcus, gingival sulcus. If we have that, and I like to round it off to about 3, if I have 3 millimeters from the end of the crown to the osseous level, I'm in much better condition. And then if I have less, and the closer it gets to the osseous level, then I have to think of what else I can do. In this particular situation, again, radiographic and clinical diagnosis is key. Radiographically, I can tell you, I see there's an open margin here. We know the patient has a PAP. Now, whether or not this is new or previous, I'd have to go and get a history of the tooth from the other dentist that perhaps this patient has seen in their lifetime. But the patient is percussion sensitive, It is uncomfortable. So I know that this tooth is going to need treatment. The question is, how should we go about doing this restoration? Well, in many instances, many dentists will go through the crown. And what happens in that case is often not very good. In fact, in this case that was sent to me, that's exactly what happened. When I took the crown off, this is what was left. And I told the patient they will now need a refund. And they were not happy. They spent 2 to 3 visits to a non-vital tooth. They had to do calcium hydroxide therapy. This tooth required a lot of visits to complete, and now it's a total waste of time and money. The endodontist must refund the money. I don't do endo in my practice. And it should have been crown off first, make the restorative assessment, remove all the caries, and I would have told the dentist and the patient, the restorative dentist, or the endodontist and the patient that this tooth is not savable because I don't have the proper potential. Even if I want to consider crown lengthening or extrusion, it would require a significant amount of loss around the roots. This tooth is not a very good tooth to save. Plus, there was caries going in the furcation, and that's the absolute bare possibility that I would never touch this tooth for a crown again. So again, I would complete the bad tooth restorative diagnosis. Again, looking at the systemic, oral conditions, periodontal conditions, everything down the board. And then I would make the decision, poor prognosis, extract the tooth, and then place implant or a fixed partial denture, depending on the scenario. So this is what we have to look at. Remove the caries and then go forward. And we're going to see this is going to be the process that we're going to do. I'm really imploring that all restorative dentists, whether or not you do endo or not, if you don't do endo, you're the one who should be making the restorative diagnosis. You're the one who should be taking the caries out and assessing the tooth before you send it to your endodontist. It's the right thing to do. On top of that, I'm going to show you what you do before you send an endodontist. It's going to change the whole way you're going to treat this tooth. And we're going to get to that today. So when we look at crown lengthening factors, actually this is going to be a big part of it, is a lot of people don't really like to use crown lengthening around any posterior teeth. But we find this study looked at a 10-year survival around treated molars. And what they found that crown lengthening may not actually affect the overall survival of these teeth unless there's an inadequate crown to root ratio. So what we want to try to do is preserve that crown root ratio when we're doing crown lengthening. I prefer to do very modified, simplified type of crown lengthening. Go in the targeted area where you have to do it. You don't have to put a moat all the way around the tooth, because if you do, you're going to perhaps create a crown root ratio that's inadequate, maybe 1-to-1 instead of being 1-to-2. 1-to-2 is far more favorable than 1-to-1. So we want to see that type of outcome. And we saw that the 5-year outcome was excellent. Actually, from 5 to 10 years, we saw more failure rates around these teeth, probably because the tooth is suffering from stress or one other issues. But the bottom line is that we can save teeth. What we need to do is control the occlusal forces with these endodontically treated teeth, particularly if they have crown lengthening done. So when I look at whether or not it's tooth restorable, if I have adequate coronal tooth structure that without violating that biologic width, I have that length of 1 to 2 millimeters, I have that width of 1-to-1 around the canal space, I'm golden. I know this tooth is going to have a great survival rate. I'll remove all the after I remove the caries, I've done the endodontic instrumentation and obturations completed, and the temporary restoration is placed by my endodontist. And again, we're going to look at this particular stage later, because this particular stage is, I believe, a big problem. I think we're setting ourselves up for failure when we perform this last part of it. In other words, placing a temporary restoration after the endodontic treatment is placed, or after the endodontic treatment is completed. So this is where we're going to make some changes. So when we look at the workflow, we see with limited coronal destruction, we can do restorations. Now, I don't have time to go into the parameters for direct restorations. I will lead you to a paper that I wrote that does discuss it very well, but you need a good amount of tooth structure and understand the occlusal forces when making that decision to do crown versus perhaps a class 1 or a class 2 restoration. I'm going to focus today instead on the massive coronal destruction, where we'll need to do crown, a single crown, or a fixed partial denture, or multiple crowns, whatever the case may be. The bottom line is I'm going to tell you the tipping point in this procedure is the core and post. And we're going to see this tipping point is going to change and transform how we do endodontic treatment, restorative treatment, and how we're going to improve the restorative outcomes. So when we look at the post, we've done the caries excavation, the tooth savable. We're going to do an indirect restoration. Do we need a post? And what's the purpose of a post? Well, we know the post acts like a scaffold. It's to reinforce the core, foundational core buildup, especially against the occlusal forces. Now, if I don't have a post in this tooth, and I just did a core buildup and I put a crown on top of that shoulder or chamfer preparation, tooth goes into function, all the stresses are going to be on that core. More likely or not, it's going to either cause stress in the material, it can crack, fracture, or actually debond. This can all happen with this tooth. The post will strengthen the core buildup, will actually make it more reinforceable because the forces will be distributed down the post canal. So that's going to be helpful in terms of saving this tooth from coronal destruction. So we want to be able to distribute the stresses along that long axis of the tooth to better control and save these teeth from failure. A lot of dentists have looked at this. Do we need a post? And these guys, this group, led by Dr. Naumann, great researcher, looked at post-endodontic restorations and did a systematic review to determine the performance of post with the success rates of endodontically treated teeth. And what they decided and came to the conclusion was, well, we don't know exactly what to do, but we know we have to do something. In other words, all the procedures, protocols are all over the place. There's no consistency in what we're doing as dentists because we use different cements, different posts, different crowns, all of this different preparation, all this can influence the failure rates. Not only that, we have no understanding about the patients. There's no discussion about the occlusal forces, no discussion about the occlusal schemes, parafunction in these studies. It's critical to know in terms of success rates. So I'm going to tell you that there's no clear evidence to support or reject the use of a post, even after no wall cavities, either for direct or indirect restorations. So what I will tell you is that when we place a post, I look at all these different studies. And this group in Siena, Italy, led by Dr. Ferrari and my other good friend, Professor Grandini, who I will introduce to you in a few minutes, have done a plethora of studies on these types of situations. So when I want to know truly what's going on and how to handle endodontically treated teeth, I look at this group led by Dr. Ferrari, Professor Ferrari. And what they did is they did a 6-year study, great time sequence of observation, placing a fiber post in pulpless teeth, pulpless restored teeth. And they found that placement of the post contributed significantly to the survival, especially if there was at least one wall. Again, if we look at a tooth like 4 walls of tooth structure, a ferrule, if there was one wall of tooth there, had a much lower failure rate. When there was no walls and just the post with a buildup, greater failure rate. And we're going to see when you have that situation, you may need to prep the tooth differently. And I'm going to give you the idea how to do that to get even a greater success rate when there's no walls left. Whether you're going to do a cast post or a fiber post, we'll get to that as well. So understand that we need to place a post in certain situations. And this is going to be our criteria. You look at this patient had a fractured tooth. This patient came to me. You can see there's craze lines in the enamel, deep overbite, but this is the offending tooth. This tooth is the killer tooth. I look at this tooth and it's a monster. This caused a massive fracture to this tooth. So I have to do something about this. Because if I just put a core buildup here and do a crown, it's going to happen again. And I don't want to prove Einstein's theory of insanity over and over again. I want to change the way I want to do things. So I have to mellow this tooth out, but I have to figure out how am I going to reconstruct this tooth so it doesn't happen again. That's the goal. So this is my criteria. And you'll see on this tooth, great ferrule potential on the facial, but the ferrule potential on the palatal was not that good. You see a lot of laws of tooth structure, but radiographically it looks great. So how am I going to handle this type of situation? So here's criteria guideline number 1. Number 1, I'm going to look at the number and location of dentin walls remaining, and that's the ferrule, after. And again, the key word is after tooth preparation. Well, the first question should be popping up in your head is how are you going to look at it after tooth preparation when you haven't even done the tooth preparation? Well, this is when you have to use your imagination. I will look into my crystal ball and say, what is this tooth potentially going to look like after I prepare all this tooth structure for a crown? I'm not going to have much, correct? So there's two differentiations here. Number one, if I need a post, it's going to be dependent upon how much tooth structure is left after removal of all the caries dentin. And then depending on how many walls are left, after tooth preparation, I would determine whether or not I need a post. So I have to look ahead. I can't make the decision based on after caries preparation. I have to think about what the tooth's going to look like after I prepare it. This is something that we don't do, and we need to do and start doing it immediately. The other thing I'm going to tell you is occlusion. You need to look at the direction of occlusal forces based on the location and the scheme. This patient is very locked in, but maybe the patient has a small parafunction, likes to chew something, bite their nails, something else has some other parafunction, chews gum. That's putting a lot of stresses every time the teeth come into contact. And maybe there's a little bit of a protrusive issue, but most likely the contact maximum intercuspal position of that lower canine to that central or lateral was in a dangerous position. It was banging into the tooth, causing stress to it over and over, and all it took was a little trauma to change the whole equation. So examine how the patient is moving their mandible. I call it the envelope of function. You must see and look for wear on those incisor teeth, because that's going to dictate how I'm going to prepare this tooth, whether or not I'm going to put a post in, and whether or not I have to do some minor occlusal adjustments to prevent stress on that particular offending tooth. There we go. Number three, and the next two ones are probably the most important parts of this presentation. So I'm going to tell you, when there's remaining tooth structure is limited, do not depend on that post and core foundation to strengthen and support the tooth and crown. Instead, you prepare the tooth to strengthen the post and core foundation and crown. So again, if I just put a core buildup and prepare the tooth, patient bangs in, it's going to break down. I need to prepare this tooth differently to distribute the forces down the long axis of the tooth. I can't put it at the coronal part. It's going to fail. And we saw this is what's happening in other studies. The reason these are failing is because we have not done the proper foundational buildup, nor have we prepared the tooth properly to put the appropriate crown on the particular situation of this tooth. So I will show you how we handle teeth like this. So when we come to the decision, and we wrote an article about this and it was published in Quintessence International last year, we saw that teeth losing both marginal ridges are more prone to fracture. We've known about this for years. We know that if more tooth structure removed during access opening, like this by Professor Scherer, have done many studies that show that when more tooth structure removed, the enamel is lost and it becomes far more flexible. Now, would I put a post in this tooth? Would I even have to do a direct or indirect restoration? Well, I'm going to tell you, I'm going to look at the cusps. I'm going to look at crack lines in the marginal ridges. If there's a lot of wear here, probably want to do an overlay. If there's even greater extension, say it's been gutted out more internally from caries, then I may need to put a post and a crown on this tooth. But I want to be as conservative as possible. Here, again, would I put a direct restoration or indirect? It depends on how the cusps look, patients and groove function. Bottom line, I'm going to put an overlay or a crown on this tooth. When you lose both marginal ridge, it's a no-brainer. You need to do an overlay and a crown depending on the tooth. And then no tooth structure, missing a great amount of cusp, decoronation, you're going to have to put a post in these teeth. So again, premolars, place a post and crown when both marginal ridges are not preserved. I think that's a pretty good rule of thumb. The others, you can make a decision based on how much caries there was. Molars, I only place a post when there's complete decoronation. I don't really place a lot of posts on molars, because instead I may not do a ceramic restoration, I may do a gold restoration or a PFM to grab more of the tooth structure to place the crown. I may use a chamfer shoulder bevel type of restoration preparation. But I will tell you the other option, as we'll see, are endo crowns, and whether or not endo crowns is a good situation for us or a bad situation, that's open to debate. So in bottom line is when there's one or two walls after preparation, so you've looked into that crystal ball and you can see there's not going to be a lot there, then you should place the post, either a prefabricated tapered fiber post with composite core buildup, or depending on the situation, you can use another type of tapered post. But I'd like to use the fiber post because it's far more easier to use, it's comparable to the properties of the dentin in terms of modulus of elasticity. It's a favorable situation, as we'll see in the literature as well. And again, if I have that ferrule, enough tooth structure with this tooth structure below this, I have the post. This is a perfect complement where I can get a great and successful outcome as long as the occlusal schemes are held in check. Again, never forget that on any tooth. When I have no walls or 0 walls and 1 wall, in this type of situation, I'm going to consider a cast post. I like to use an indirect method where I take an impression. Others like to do direct method using either Duralay or GC pattern resin. I'll take the impression using a post replica or even the post, pour up a model, and we found a little bit better adaptation, more accuracy of fit. I will actually treat this gold as a bonded restoration. Gold is like a zirconia. I can sandblast with cojet or aluminum oxide, put a metal primer on the internal aspect, and then cement it with a resin cement, whether it's core buildup or a self-adhesive cement, resin cement. That would be your choice, and I'll give you my assessments about that in a little while. But then again, I know using a cast post with an anterior tooth like this, with adverse occlusal schemes, with that ferrule or manufacturing ferrules, you'll see, will resist failure much better than considering some of the other options. So that's why I need to look at the occlusal schemes, determine if I use fiber post or cast post in this situation. And when I have this, I can go to bed at night sleeping very comfortably, knowing that I made the right decision. I just need to use either a PFM or a zirconia crown, probably a more opaque zirconia crown. Maybe I'll use a facial veneer on it to give characterization, but I got to block out the gold. So I can't use a Emax or a Celtra Duo glass ceramic because that gold will show through the ceramic. So you just have to be more selective in terms of the material you're going to use after that. In terms of the posts, look at this. We have all these different types of posts. And I'm telling you, there's so many posts, I don't even know what to do with them. I have so many in my office. It's impossible to believe how many different types of posts are made out there. Question is, which one is best? Should I use metal posts? Should I use fiber posts? Should I use carbon posts? What shape is best? Is parallel, tapered, whatever the case may be? I got to make a decision. Now, conventional wisdom tells us that if we use a fiber post and we have a vector force, whether it's oblique or horizontal, if there's an extreme force, the fiber post will crack at the coronal aspect. As opposed to a metal post, if we have the same forces, the forces will be directed down the root because of the modulus of this root. This metal is much stiffer, and all the stress will go to the apical portion. That's what conventional wisdom tells us. The question is that true? Is that accurate? Well, let's look at the evidence. And we see this is a meta-analysis done in 2015 comparing prefabricated metal, carbon posts, carbon fiber posts, cast metal posts, and regular fiber posts. And we see that prefabricated metal had the highest amount of catastrophic failure rates, as similar as at the carbon post. And again, non-catastrophic means that it was still savable, but we had to fix it. We get a lot of failures on the carbon fiber post, but we see, ironically, that the cast metal had the lowest catastrophic failure rates. Many people would believe that should be the exact opposite. And then the fiber post had the second least amount. And we're going to see the reason why this is true, why these particular shaped posts, whether it's metal or fiber, have the least amount of failures. Yes, there are a higher amount of non-catastrophic failure rates with cast metal, probably because the crowns came out, or the posts came out because they weren't cemented properly, or they used the wrong cement, or the crown wasn't prepared right. But the bottom line, it was still savable. And the same thing with fiber posts. Perhaps the fiber post broke. You can take out the fiber post. Not the greatest day in the office, by the way, but you can do it. It's retrievable. You'll have to basically drill it out, but it can be done. The question is, how far down did you put that fiber post? And that's what we're going to discuss next. So the glass fiber post achieved the optimum catastrophic and non-catastrophic failure, probably because of its low modulus of elasticity, but the cast metal was the most surprising. So when I look at post-shaped evidence guidelines, and we can compare fiber post to metal post, you want to use a tapered post, and that's the reason why the fiber post and the cast metal post had the least amount of catastrophic failures. It matches the anatomy of the canal. If you're using a parallel post, it's not matching the anatomy of the canal, putting more stresses on the cement, and if the post loosens up, it's going to create a lot more stress to the root structure. So we want to use a post to match the exact shape of the last file used for instrumentation. Makes sense. And we're going to see, we're going to take that even a step further as we go along. Anatomic post directs less stress towards the remaining tooth structure, keeping all the stress within the body of the tooth. Net result, you have improved bond strengths to the resin core material and less fractures. And the evidence is there to show that, as I already showed you. When we do the post-face preparation, I can tell you, I don't particularly get any enjoyment out of making post faces. And I know a lot of my colleagues feel the same way. You have to determine the appropriate diameter, remove the gut aperture. You can either use a heated instrument or a small gauge glitter or piezo reamer, and then you initiate the drilling with the post, and then you match the post to the corresponding drill. Whether it's yellow, red, depends on the size of the canal, but it should match the last instrumented post, and in this case, it was the post drill. So we want to understand that this procedure is necessary, but is there a better way around it? Well, I can tell you that when you look at using post drills, we see that post-face preparation with these drills can create crack propagation. So we know it is weakening the tooth. It makes sense. We're putting much more stress on the canal when we're taking a post drill, especially widening it with the post drill. So we have to think about, is that contributory to failure? It absolutely is. So we have to think about, maybe we need to do less post drill space preparation. And what about using the microscope in terms of creating a post face? Well, the microscope actually creates better cleaning of the canal, and because of that, we can get much improved bond strengths to fiberglass post to the dentin. So again, we know the microscope is now a standard of care in endodontics. Whether or not you're a restorative dentist who does endodontics, or you're an endodontist who's going to make a post face, the microscope is absolutely necessary. And as we'll see, the microscope going forward may become the standard of care in restorative dentistry. And that's probably going to be in the very near future, hopefully, because it's something that really improves our outcomes. It's changed the endodontic profession dramatically in their successes. And there I am doing some teaching with a microscope. I've been using the microscope for about 7 years. And I can tell you, this is the main microscope I have in my practice. It's called a Zeiss microscope. It's an Extaro 300. The uniqueness of this microscope over other microscopes is that it has these augmented visualization modes. I can use many different modes to help me see better, to do better detail, better precision on my preparations, whether it's caries excavation, whether it's tooth preparation, post-face preparation, every preparation. I can tell you, with all the different materials we have in our operatory, this is the one thing that's never let me down. Never. Every time I use it, I get a better outcome, period. So this augmented visualization, which you don't see on other microscopes, I have this fluorescent mode. It helps me identify the caries when I'm removing defective restorations. This allows me to be much more, less invasive. I'm preserving tooth structure. It's far better for the tooth. And then we have this true light mode. It actually, instead of using that nasty orange filter, I'm using a light that actually I can see very well. I can shape up the composite before I hit it with a curing light. That's the key. I want to make sure there's no excess on the margins, because I'm going to have to take that off and hurt the tooth. You know, as restorative dentists, we do a lot of damage to our teeth, to the restoration, while we're finishing it. We have to minimize finishing it. So the best way to do it is to see it. And to see it, use the microscope. And the last slide, I have this no glare mode. It actually helps me differentiate composites from hard tooth tissue. So I can actually see it while I'm removing a veneer. I can see composite over the regular tooth. I also use this no glare mode to see shades and characterization. So I have multiple abilities with this microscope, far more than other microscopes. It's an absolute, it's changed my life. It's changed my world. And now to the point where I teach students. I've taught over 700 dental students at Penn Dental how to use the dental microscope to do restorative dentistry. And many of them go on to tell me that this was one of the best courses they ever took in the school. It's actually amazing because they're in great, look at their position. They're standing up straight, no back, neck strain, no eye strain. This is the greatest, one of the other great things about the microscope. It saves your body. Our bodies break down from dentistry. This allows me to do dentistry in a relaxed, easy fashion. It actually makes it more enjoyable and it makes me better. That's the goal, always. So going forward, that's our clinic. This is placing a post-space preparation on a molar. This is a dentist that came to me to have me do this. Wanted a post in the canal, felt more comfortable, and because the patient was a dentist, I said, okay, would I necessarily have to put a post here? Well, after preparing the tooth for an overlay or an onlay or crown, probably not. I think there was a lot of tooth structure available, but nonetheless, it doesn't hurt. The only thing is it just takes a little bit more time. The endo was done. Patient came to me with the endo done. And again, we may choose to do this a little bit differently going forward. So there I am. It takes time. It's tedious. You have to charge your patient to do this procedure, but you have to do it under a rubber dam. And there it is. I can see so much better with the microscope, just going into different magnifications. Again, when I'm going to different magnification, notice that it's always in focus. That's called parafocaling. Big advantage in terms of doing using the microscope. And I can just shift them back and forth to my eye comfort level, and also so I can see visually with my indirect mirror. And then I decided to go with the post that fits the canal best. This is a matrix system called the Paladin 360. Enables me to just put it comfortably around the tooth without a big thing sticking out of their mouth. Very easy to use. And then I'm going to go ahead and clean the tooth and then adhesively cement my post. And there's my canal, and we're ready to go. So I can tell you the microscope is a big advantage for me in every aspect of my profession right now. So what's the one way around getting away from post-space preparation with drills is to do immediate post-space preparation. What does that mean? At obturation, when you best have the ability to see the anatomy of the canal, is to do the post-space preparation right there. The only thing is you have to know if that tooth's going to need a post. And if you're not doing the endo, then your endodontist needs to know if that tooth's going to need a post. But that information should come from you, the restorative dentist. After you've done caries removal, you're going to know, basically, again, looking and using your imagination, how much tooth's going to be left after preparation. So in these situations, I remove the caries, and as you'll see, I do it a little bit differently now before I send it to my endodontist. Before I send it to my endodontist, I will call the endodontist and say, you need to put a post space, and I will give them the exact measurements that I want to do, and I'm going to give you that formula today as well. So you should be the quarterback here as a restorative dentist. The endodontist, if you're doing this case, you should call your restorative dentist and say, hey, I think this tooth may need a post space. I'll make the space for you. I'll give you the post, give it to the patient, and send it back to you. All you have to do is put the rubber dam on and drop it in with some core material bonding agent. It's easy, and you can charge the patient for the procedure, and they've done the post space preparation for you. It's much, much better outcomes because, and we see in the evidence, less manipulation of dentin walls with post drills, less potential contamination during the preparation of the post space, but most importantly, the post matches the shape of the instrumented canal instead of changing the shape of the canal to match the shape and size of the post. Too often, we're going in and over drilling the internal aspect of that canal with these post drills, taking away healthy tooth structure, weakening the tooth, creating crack propagation, and especially if you're not using the microscope. So this all comes together as the most logical way to proceed doing the procedure. Do it at obturation, whether you're the endodontist or whether you're the restorative dentist doing the endo. It should be done now. So when I look at post-space preparation, we're going to compare cast post. We know from the evidence, and again, I have many articles down here that I'm going to look at that describe the evidence for this. We know the post length for a cast or metal post, if you just use a metal post, should be approximately 2/3 the root length from the coronal orifice of CEJ. I like to use the coronal orifice and the CEJ as my reference point. I think it's much more predictable, and if time allows, I will explain why it's better than any other reference point. For fiber posts, you're going to see basically that both posts, if you're comparing fiber and cast, both post shapes are anatomical. I already told you the advantage of that, especially if it's done at obturation. We get that anatomical shape of the post. Secondly, we see that post lengths are identical. Now, does that mean we're going to place the fiber post the same length? Well, I'm going to tell you we're going to reposition the fiber post differently within the canal space. The evidence shows us that we don't have to go 2/3 down the root for the fiber post. We can actually put it at a reduced depth in the canal space. This is a big, important evidence-based decision, because even if this fiber post breaks, we don't have to go down as far down to remove it, to drill it out. And we can see that it didn't make a difference going 2/3 in terms of retention of the post, bond to the post, everything. In fact, we know the canal bond strength is weaker down here, so we don't really want to bond down there anyway, and I'll show you the evidence about that in a minute. So that's the difference. And and I say we, Professor Grandini from Siena and Professor Martignoni from Rome, got together a couple years ago to sort of explore the evidence and to write an article so we can universally throughout the world come to some decisions on how best to restore endodontically treated teeth. And we wrote an article, and again, I certainly recommend you to go see this article. It covers a lot what I covered in this presentation, plus more, as I do cover when to use indirect or direct restoration. But basically, it reviews the literature for post versus no post and swells the importance of that coronal seal. And you're going to see I'm going to take that even a step further. And we're going to do that in our next article, which is coming out in 2021. So I'm going to tell you, we call this the SMART. It's better than the dumb fiber post length replacement protocol, but it's smart. It's smart because it's easy. It's also smart because it sort of matches the initials of our name. It's SMA, that's the initials of all our first names. RT means rule of thirds. And that's going to be the key part here, the fiber post length placement position protocol. You know, we can guess. Well, I can go halfway down. Are you going to go halfway down? You need to know because you're going to be doing this at obturation. So I'm going to tell you what you're going to do is, again, use this reference point, the root orifice. It's going to be the easiest way. I'm not going to use the osseous level. And again, I'll get into that in a little later. I'm going to measure the root length from that root orifice. And in this case, it's 12 millimeters. From there, I'm going to multiply that root length by 2/3. Remember the rule of thirds. So I already done it 2/3. I'm going to multiply it again by 2/3, and I get 8 millimeters. 8 millimeters will give me the length of each post. Remember, I told you, you're just going to reposition this fiber post differently in the canal. That gives me the length of a cast or metal post. Now, what do I do with the fiber post? How do I determine where it's going to be? I'm going to give you a simple mathematical equation. All you're going to multiply is 8, the fiber post length, into thirds again. So all I'm doing is 2/3, 2/3. That's it. It's easy to remember. And you'll see that I'm going to get 2.5 and 5.5, which equals 8. And I'm going to move that fiber post up 2.5 above the root orifice. There it goes. And 2/3 below the root orifice. What the greatest part about this is that this post is already going to be in the proper position that it needs to be covered by the core material. I no longer will have to touch that post. Every time you touch that post during preparation, it weakens the bond to the dentin and to the cement. So you can see there's many advantages, and again, you're going to see the overall perspective of this in a few minutes. So I'm moving it up 2.5. That gives me the exact measurement. So in fact, at obturation, I'll use heat or ultrasonics depending on your obturation technique. If I'm doing sealer-based single cone technique, all I'm going to do is I'm going to use my master point of 6.5 and then cut it there and put it in with my bioceramic sealer, and I'll have the space made. If I have to go and use some of these other lateral condensation or warm condensation techniques, then I have to go back and remove some of the gutta percha and sealer with either a heated instrument or a type of drill. But it will be less invasive, no doubt. Because the person who did the canal or did the obturation knows the canal anatomy very well. But I usually recommend a heat instrument. It will remove it pretty quickly and effectively. That's the beauty of this. I've given you the exact position of that post, so you never have to touch it again. And you'll see the importance of that. Again, if I'm doing a cast metal, I would use just leave 4 millimeters of gutta percha, whether it's master point or I'm going back in and removing some post obturation with the other techniques, as opposed to the single cone technique. So there are 3 different techniques. You choose which one you do as an endodontist. But I'm going to tell you that key reference point is going to be the important point. So that's how I'm going to do it. It's always going to make the difference. And when you see the outcomes with using fiber posts, I don't usually we go down here. I don't have to go as far down. I have a good ferrule here. Everything is placed. The ideal post matches the same shape as the endodontic preparation. No need to alter the shape of the canal to match the post. The post fits passively in the shape of the instrumented canal. This should all be clicking in for you right now and making sense, because it's truly the way to do it. And we're going to see the advantage of this smart technique now, because with cast post adhesion, there are 2 ways it can fail. Bond breakdown happens between what? the core buildup or whatever cement you use to the root dentin, and the post to the resin cement or core buildup. Those are two methods of failure. And if I have this post sticking up here after I cemented and I cut the post after it's cemented, more weakening of both bonds. Absolutely. So I want to be careful how I do that. So when we look at the clinical factors affecting bond strengths, ready, we told you about the shape. What about irrigants? Are irrigants, sodium hypochlorite, EDTA, affecting the bond strengths? We're going to look at that closer. Different obturation filling materials. We know zinc oxide eugenol is still a sealer obturation filling material. You can't use that in today's world of adhesive dentistry. Zinc oxide eugenol does not work well with bonding agents. So if you're an endodontist, you want to consider going to a newer type of sealer. If you're a restorative dentist, the same thing. So I'm going to tell you that you need to change sealer based on the fact that we're going to more adhesive types of restorations. The fiber post-treatment protocol, I would say keep it clean. You can put a little silane on it. It will enhance the bond to the core or cement, but it's not going to make a major protocol. What's going to be the difference is creating what we'll see is the cement protocol. And we're going to go through that as well, and how you light cure it. Certainly light curing and getting that cement as much as you can light cured will be important, but the dark cure and using a cement that does have a good dark cure is going to be critical too. And as we'll see, the age of the patient will make a difference in what I do, as I already alluded to. And there it is, just came out in October, looking at root fractures in seniors, the consequence of acute embrittlement of dentin. We think, or normally, and the biggest myth is that endodontically treated teeth are more fragile, more brittle. They're only more brittle as we get older. Usually young adults, teenagers, even people in midlife, the moisture level of the dentin to whether it's endodontically treated or vital is pretty close, similar. That's not the reason why these teeth are fracturing. It's not the reason. But we do know radicular dentin undergoes an embrittlement with aging, the radicular dentin. Okay, there is some change here, but more so here. Degradation is the largest in the apical third, so pulp expiration accelerates the aging process. So whenever you're doing that, it's going to create more brittlement in that apical area. So logically, the clinical significance is when I use a fiber post or a cast metal post in elder population, because A, I'm not bonding in the apical third, and the fiber post modulus has less stress to the embrittled dentin. So this is why when I look at the aging patient, no matter what, I'm going to use a fiber post over a metal post, period, because it's going to be gentler to this brittle dentin. Makes sense. And that's where research helps us make decisions. But this is my goal. I want to create that monoblock around the post during the cementation and buildup, resulting in no disruption of either bond during preparation. There it is. Now, I'm going to get a really good monoblock all the way down. I may have the post leaning against the canal space here, depending on how it's positioned, but that's okay. I mostly have cement. It's a thin layer of cement around here. And again, this is all sealed already. So if I can create this monoblock, it's golden. It's like doing a cast post. It's going to be the most secure, least disrupted, more beneficial to the outcome of the restoration. So when I do buildups and core and post, what materials am I going to use? Well, we can see in this picture, there's several different ones. We have Fluorocore 2X and we have Clearfield DC Core. The bonding agents with Fluorocore 2 Plus is called Prime Bond Elect, which is a universal multi-mode adhesive with self-cure activator. Why do you need a self-cure activator with this bonding agent? Well, if I just use this bonding agent, and this is a light cure bonding agent that I can use with any composite, but if I use it with a dual cure, I must add the self-cure activator. The reason being is that this bonding agent, after it's put on the substrate, the dentin, air dried and cured, remains an air inhibited layer. In that air inhibited layer are uncured acidic monomers. When I place that core material on that air inhibited layer, those uncured acidic monomers attack the tertiary amine. It's like an acid-base reaction, and the core material will not fully dark cure properly. It weakens, and that's why a lot of dentists didn't know this when this first happened. They assumed that they can use one bonding agent and it works, and there's still dentists today that do it, unfortunately, and the core material will come out of the tooth into the impression when they take the impression. So that's very key. So bottom line is that I can use this complex. So this is very versatile. I can use this with either one of these. This company, Caries, has a clear-filled universal bond quick. It's the same thing like this, universal light cured, but you don't need the self-cure activator with their core material. They've made it compatible, but I can use this with this, but I can't use this with that, with the fluorocore. But I could use this with either one of them. So it's really pick your choice. And I like the versatility. These are both outstanding materials. You can't go wrong with either one of them. They're both great. And the reason I like core materials is because the evidence shows me that using dual polymerizing core materials is preferable to maybe using self-adhesive cements because there's better hardness at all depths of that space. That's going to be the key part. It's stronger, better flexural strength, better compressive strength. It's going to work better than a weaker cement. Makes sense, and that's why some of these other cements many dentists are using don't work very well, and they have greater failures. So you got to use the best. We actually did research. A couple of my colleagues at Penn, Dr. Monte, Dr. Blatz, Dr. Dvorak, we looked at core materials, and we looked at them in a particular way. This is even before we started considering them and looking at their effect on the bottom line with core and posts. We looked at them as how do they react in a tooth, and is there a benefit to delaying the cure of core materials? Because if we cure it immediately, it's basically a light cure material. But if we delay the cure or just let it auto cure on its own, then it becomes a self-cure material. Is there a benefit of letting it cure a little bit, lowering the velocity of polymerization, and then light curing it? The key part of core materials or dual cure materials, whether it's cement, when you're putting in a crown, or core, you need to light cure it. Our question was, what was the best time to cure it? Was there a difference? And what we found was fascinating. In fact, this has been reproduced by many other researchers and is now being used in DFUs for many core materials and cements. We found that delaying the cure made a significant difference. We also looked at volumetric shrinkage of the same type of scenario. We couldn't publish this because the company that sponsored the study, their product was the worst. So we couldn't put it in and write up the article, but I can tell you the volumetric shrinkage and the micro leakage were absolutely comparable. We found that after 30 seconds, waiting 30 seconds improved the leakage and lowered the shrinkage significantly than auto curing. If we let the material auto cure on its own, even though it had a lower velocity of polymerization, we found that you needed to auto cure, you needed to light cure it, because the material underwent aging, and we found leakage even under the light auto-cured core materials. We did these in class 2 tooth restorations that underwent aging through thermal cycling, and we found that, in fact, self-cures don't really behave well long-term. You need to use a dual cure, but you need to light cure it, and we found 30 to 60 seconds was the key. Other studies have shown that even extending that couldn't hurt, but we found 30 to 60 was a sufficient amount of time. So delaying the cure compared to immediate cure reduces micro leakage and volumetric shrinkage of dual cure materials to varying degrees. That was our conclusion. So here it is. This is a little speeded up to help. There I am placing my bonding agent. I'm using, in this situation, the Primer Bond Elect with the self-cure activator. I mixed equal drops. I put it in, and you need to air dry this very well to remove the solvent. If you don't remove the solvent, you're going to have core polymerization of the core material. Don't just put it in and light your air dry it very fast. You'll see that I do this incrementally. I put the cement in, drop my post in, I pump the post up and down to remove any air bubbles, and I position it in the right position, and then I'm going to put my core material in incrementally. I will never fill this from bottom to top because I'm going to get much better cure and adaptation. And the other part of this is that we found is that you need to wait 5 minutes for the complete dark cure to happen. So I'm really in no rush. I wait 30 seconds, cure it, put another dose in, and wait 30 seconds and then cure it. And then I'm going to wait maybe another 3 or 4 minutes for it to fully cure. If you don't do that, what happens when you go prep the tooth, it may not be cured and your diamond's going to slide right in. And we've seen it because it hasn't cured properly. So make sure you just wait. When you're putting in a cement with a dual cure material, the same thing. Wait 5 minutes before you start checking bite or adjusting occlusion. You will affect the bond significantly if you don't. So what about endocrowns? Big play on endocrowns. The question is, do we need endocrowns? Are they making a difference? I think if you have chairside milling in your office, no doubt it could be an advantage. But Problem is the fit. Is it reliable? Is it accurate? And we're finding that premolar endocrowns in clinical studies, and this is a systematic review done just recently, reported a higher failure rate than for molars, probably because of the anatomy of the canal. Far more difficult. The other thing is you can see that, it's like a little extension into the canal. Survival rates were also considerably lower than premolars restored with conventional post and core crowns. So we see that maybe for molars has higher success rate, but we know doing these things on molars and cementing them in with adhesive cementation, you need good isolation, you need rubber dam utilization. It's far more technique sensitive. The question is this the best way to do it? Well, what happens if you have a failure of the crown? What happens if the crown chips and cracks? Getting this out is not going to be easy. It's going to be a miserable day in the office. So I never like to set myself up for a failure long term. When I know that we know these crowns will not last forever. And when it does have to be replaced, I want to be able to replace it easily. Endo crowns, in my estimation, does not make it easy to retreat anything. What happens if the endo fails? Then it's microsurgery. But the crown fails, I have to redo it, and the tooth's going to be worse off down the line. Is it supporting the tooth better? According to the literature, not for premolars. The question is there a better way? I'm going to show you there is. So tooth preparation is critical, as I alluded to many times during this presentation, for endodontically treated teeth. What I like to do is on the shoulder, if I'm doing an anterior tooth, and we're talking anterior right now because that's where we have those oblique and horizontal forces that are very detrimental to the tooth, particularly in endodontically treated tooth. I'm going to make I like to use a modified shoulder diamond, 847 KR diamond made by Comet. I think it's a great diamond to use, whether it's 014, 012, 016, or 018, that's your decision. The wider it is, the more aggressive the preparation is going to be. But I like to use a shoulder, modified shoulder, gives me that rounded internal line angle, flat butt joint. But on the lingual aspect, the other 180 degrees, I'll use the same shoulder, but what I'm going to do is maybe a half a millimeter to 1 millimeter bevel, 180 degrees. What I'm doing here is I'm manufacturing an additional ferrule. So the patient, if you think about it, forces are coming in, hitting here. If I have this bevel, it's going to protect against those forces. The forces will not be here on the coronal aspect. It will be going down the root. Therefore, no stress on here. This won't break, won't crack, and it won't weaken. That's the goal. So when you have these adverse forces, you need to prep differently and then choose the right prosthetic tool selection. In this case, I used a PFM. I put a bevel here, bevel here. This was a vital tooth. I did not need a bevel. I had plenty of ferrule. I manufactured an additional ferrule here. And again, if I didn't have any core here, I would still manufacture a bevel. If I'm using a molar and there's no decoronation, I'm going to put a bevel 360 degrees around. I can't do a ceramic restoration, so it's going to have to be a PFM or a gold. Don't do bevels with ceramics, all ceramics, CAD/CAM restorations. So here, again, bevel gives me added support, especially against those monster patients that kill teeth, or destroy teeth. Again, high additional power function. Use this 180 degree palatal bevel in metal for bracing effect to prevent fractures of endodontically and post-treated teeth. I'm going to show you that in the evidence, it's also there because they put a palatal ferrule and showed that it significantly enhanced the fracture resistance of fibrofos restored teeth. This was done in China. A great study by Dr. Zhang, who does many studies on these types of endodontically treated teeth. What they also found in another Brazilian study that beveling the shoulder presented the highest fracture resistance in group without any remaining coronal structure. So there, if I have a molar, I may choose to do that over placing an endocrown. If a patient's in groove function, they're going to be disrupting that bond significantly. Whereas if I can create that ferrule around the root, that's going to support it much better. Less stress to the tooth, less likely it's going to fracture or the crown's going to come off. Again, I want to do what's best long-term for the patient. Again, we see it was similar to group with 2 millimeters of remaining structure and a shoulder or chamfer prep. So there is the evidence. And now, this is how I do it. I take a very thin, fine diamond. And all I'm doing is I'm trying to keep it as super gingival as I can, equal gingival. I don't want to go way down below the gum. But in this situation, I'm just using a short stroke going across to about 180 degrees on the palatal aspect. I am not beveling. the facial. I'm using a butt joint. It's simple. The microscope allows me to see this much clearer, much more better, much easily, so I can do more precision dentistry. So when I have a compromised anterior tooth, I will use this type of restoration. This patient had existing cast posts, didn't touch them, left them alone. This was pre-op. Patient came in, lived in England, London, England, came to see me in Philadelphia, and this is the post-op. All I did was just create the proper health, proper retention, and this was loose. When he came in, this was loose, it cracked, and that's what the problem was. With that additional ferrule on the palatal, not going to loosen at all. That's the goal, preservation. So I'm going to end this way, and I'm going to sort of tweak things a little bit differently for you. I've given you the conventional way of doing endodontics and restorative treatment. And we'll see that maybe we, as I alluded to earlier, maybe we're setting ourselves up for failure. Maybe we should consider doing something different. And this guy, who I already talked about, his theory of insanity, also said this one day. He said, the world as we created it is a process of our thinking. It cannot be changed without changing our thinking. Think about that. So I'll tell you, I'll give you an example. This patient came into University of Pennsylvania, School of Dental Medicine, had a vital tooth, secondary caries under the restoration, as we see here on that second premolar. Lingering, cold lingering, that's always going to be one of the symptoms. Lingering more than 30 to 60 seconds. If it's lingering cold when I'm checking it with endo ice, then I know this tooth has irreversible pulpitis. Percussion, it was sensitive, probably because he's been like this for over a month and just couldn't get back in. He's been suffering. So what we did, we decided we're going to go and treat it. Probably going to need endodontic treatment. We do the caries removal. Again, that's my endodontic. I've done my endodontic diagnosis. My restorative diagnosis is that the caries was not going deep. It was there under the restoration, cleaned it out. No pulp exposure, but that's okay. I mean, I could certainly put a restoration temporize and see if it's going to develop endo, but based on his symptoms, I'm pretty certain it's endodontic irreversible pulpitis. So the traditional approach, endodontic treatment is started. My question to you, is that the best way to proceed? Should we be starting endo right now? So I'm going to tell you, when we look at the evidence, the effect of irrigation on core adhesion. This is just a microcosm of the evidence out there. And these are all recent articles. And we see that sodium hypochlorite definitely affects the dentin properties. And it is concentration dependent. The higher the concentration, the more effect it's going to have. But it results in the disintegration of the organic dentin matrix. It makes it fragile. So if you leave sodium hypochlorite on dentin for 30 minutes to kill all the bacteria, you're actually weakening the tooth significantly. And this is a problem. And I believe this is contributory to the failure of endodontically treated teeth. In fact, if you use 2.5% sodium hypochlorite, according to the evidence, negative effect on the micromechanical retention of the glass fiber posterior dentin. Now, EDTA removes the smear layer. No doubt that's good for bonding. But in combination with sodium hypochlorite, it, according to the evidence, prolonged use in high concentration will or may increase the risk of root fracture. So we must think about what we're doing. I'm not saying remove sodium hypochlorite from the protocol. I think it's a very effective cleanser. And whether or not we can use chlorhexidine or some of the other materials that are being developed out there in the future, perhaps we can. But right now, sodium hypochlorite is the best. But what we have to try to think about, what's it doing to the dentin? Is there a way around that? Can we avoid this from touching the dentin? Well, think about it. This study came out in 2014. This really gave me some insight about what maybe we should be doing. Dr. Kretschy, great researcher, and his group in Switzerland, looked at immediate endo access after sealing and looking at its effect on the core buildup. And what they found, that placing the core buildup immediately before endo had a significantly higher adaptation compared to putting it in after the endodontic treatment. So in fact, they concluded on endodontically treated teeth, it may decrease coronal leakage. There it is again. We started at the beginning, what coronal leakage is doing to the failures of endodontically treated teeth. And now we've gone full circle here, where we're finding what's happening. Maybe it's the irritants that are contributory to the coronal leakage. So is there a way around it? As Dr. Kretschy says, in his study, maybe we need to consider doing the core and post a little bit differently. So what are we going to do here? We are going to use the core material, and we're going to place an immediate endodontic seal and foundational core buildup. Now I use the elect with the self-cure activator with the fluorocore, and there it is. At worst case scenario, I've already strengthened and sealed the tooth. My endodontist can put a rubber dam on this tooth, so when we have wide breaking teeth and they're trying to get isolation and there's seepage, why not go ahead and do the core buildup immediately after caries removal to seal the tooth? And this is the tipping point in the procedure. We're going to do this automatically. Traditionally, again, we would do caries removal, access, shaping, irrigation, obturation, and place the core buildup. Now what we're going to do is we're going to do caries removal and do core buildup immediately before the endo treatment. Yes, before the endo treatment, to seal the tooth, strengthen the tooth, and most of the irrigants will not be affecting the core buildup. Therefore, it won't be as weak. The only time we're going to see affected is down the canal, but we have that monoblock already set externally. That's the key in terms of getting greater success here. So are there other tipping points here? What else can we do here to improve the outcomes and maybe do it better, faster? Well, I'm going to tell you, we're going to go ahead and prepare the tooth even before endo. And I'm not only going to prepare the tooth, if I have chairside milling, I can scan it, design it, put it in my milling machine, and then while it's being milled, I'm going to perform endodontic therapy. So I do endotherapy immediately after crown preparation and scanning, and while it's being milled, endotherapy is being done. I'm saving 30 to 60 minutes, maybe more on the workflow. I'm doing two things at once. If I have the ability to do this, this is a great procedure. I can do it all in one day, in 1 3-hour day. And this could be the most profitable procedure that you can do. And again, it has to be done under the microscope for better precision, the prep, the endo. If I wanted to drop a post space here, I could. I didn't need to do so, but I'll show you that it's not that difficult. It doesn't change anything I'm doing here. Because after the access is done, I have the ability to drop a post space and drop the post, and I'll show you how to do that. In this case, no post because I have a lot of tooth structure here, but all I'm going to do is after the endo's done, and before I try in the crown, I'm going to fill up the access space, but I'm going to leave a little depression right at the coronal aspect so that the crown can see. If I fill it to the top, it won't work. And how am I going to do that? Well, what I'm going to do is I'm going to treat that whole existing composite with phosphoric acid. I put silane coupling agent on that composite, air dry it, and then I'll use my core material, bonding agent, the elect with the dual cure self-cure activator and the fluorocore. If I had a post space, same thing. Do the same exact thing, and then I just drop the post with the fluorocore and then fill it up, creating that monoblock around the post. By using this technique, ensures a better coupling between the existing and old new composite. That's what we want to achieve. And there it is. By the time I'm done with that procedure, the endo and the core buildup back or the post, crown's ready. I try it in. There it is. This is Celtrip Duo. It's a zirconia reinforced lithium silicate material, and it's adhesively cemented with a resin cement. There's the before and after. At Penn, we have a team. Dr. Eastlein is a second-year perio-pros resident, going to be a star in dentistry. Dr. Elsaby is a phenomenal endodontist, now in private practice and as well teaching at Penn Dental. And I did all the restorative dentistry with my dental microscope. There it is before and after, beautiful. If in fact Dr. Elsaby had made a access and broke the core material, then I would not have been able to finish the procedure one day. I would have rebuilt the core and then placed the temporary and then had the patient come back the next day if time was not allowable. So again, the tipping point is this. There it is. I am doing my core buildup, caries removal core buildup here instead of here. And I'm saving 30 to 60 minutes off the workflow. This is what we call doing faster, better dentistry. So in conclusion, there's no treatment plan without the complete endodontic restorative diagnosis. Do not skimp. Again, if you're a restorative dentist who does not do endo like myself, then I'm going to do all the caries removal for my endodontist. I'm going to make the restorative diagnosis. I'm going to put the core buildup right in immediately, and he will do endo through the buildup. That's it. So, and I will tell you that it's very easy, even if you had a pulp exposure, to dress it. And I'll hopefully be able to explain that in a few minutes. Preservation of tooth structure is key for the survival of endodontically treated teeth. The more tooth structure you remove, the more likelihood it's going to fail. It is not because of embrittlement, it's because of excavation of too much tooth structure that causes the failure of these teeth. And poor crown, of course. After caries removal, remember this rule, strengthen the tooth with the core buildup. Then when possible, if you have time, impress it, whether it's scanning or milling, scanning or conventional impression. And if you have a mill. I don't have a mill in my office, I mill a pen. So I do conventional impression or scan, send it to my lab to outsource the fabrication of the crown, and he gets a temporary. But the key is, patient comes back, it's done. And then prepare the tooth to support the post and core and crown. Remember I told you how we handle these endodontically treated teeth? If you need to, put an additional ferrule, manufacture a ferrule by placing a bevel. It's the greatest way to preserve teeth, particularly fragile teeth. And don't depend on the post and core to support and strengthen the tooth. These two are the key parts of the whole procedure. So you see how I've changed everything dynamically. I haven't recreated the wheel here. All I've done is change the position of when we do certain things and give you some good evidence why we need to prepare teeth a little bit differently in those poor occlusal type of patients. And remember, dietary analysis is also very important. Patients eating hard foods, you need to document it and instruct them to stay away from them because their teeth will fail faster. And if they have parafunction, same thing. Get them in night guards. If in fact they show some parafunction, stress the teeth will cause expedited failure of every type of restoration. There's my contact information. If anybody needs to contact me any further for any additional questions, I'll be happy to answer them. If you ever want to come visit me, there's my address. And if you ever want to see me again in a presentation, there's my website. I think I'll entertain some questions now. I thank you for your attention, and I hope everybody got a lot out of this presentation.
Thank you so much, Dr. Atlas, for that really comprehensive presentation. It was really interesting. We have some questions, but before we get to those, I would like to invite our viewers to use the question box in your control panel to ask any questions that you have. The first question is, what criteria would you use to decide to place a posterior composite instead of an overlay or crown on an endodontically treated molar or premolar?
Oh, okay. That's a good question. I sort of brought it up a little bit, but what I'm going to look at is we need to have about 2 to 3 millimeters of tooth structure, at least 3 walls of it. And then I'm going to look at the patient's occlusion. Are they in group function? Do they have a lot of wear on the teeth? Are there cracks in the marginal ridges? These teeth are stressed. So I just put a composite there. The flexure will continue if the patient has parafunction. If the patient chews ice, chews gum, eats almonds, things like that are going to stress those teeth out. More likely they're going to fracture. So I put that whole complex into my decision-making process. Occlusion, dietary habit, and appearance of the tooth, and how many walls of tooth structure are left. This is explained very well in that article that Professor Grandini and Professor Martignoni wrote with me in Quintessence. And again, the technique that I just showed on post-space preparation is going to be in our new article coming up. So look for that also in Quintessence International.
Okay, second question. How does the smart fiber post preparation work with teeth with moderate bone loss?
So I think when you're approaching teeth with bone loss, you must look at them differently. And this is why I don't like to use the osseous level as a reference point for root length for post-space placement, say that 3 times fast. Because if I osseous levels down here, that's going to affect how far down I'm going to go down the canal for post-space. If I want to go 50%, remember your post ideally should be 50% past the coronal level and 50% below the coronal level. So the coronal level is way down, you can't use that rule. But if you use the CEJ, then that's a reference point that's always consistent no matter what the bone level is. But I'm going to tell you, many times you can do a sort of a bevel preparation around these teeth and not have to use a post. If you're manufacturing a ferrule and you have enough tooth structure, and you're not going way down subgingival, which you probably wouldn't because there's bone loss, then maybe a post may not be necessary. Post can't hurt. It won't hurt the tooth. So whatever you can do, if you're missing a lot of coronal tooth structure, put the post in, do the buildup, but manufacture that additional ferrule on that root, particularly with endodontically treated teeth. Fonze and Vire has showed us that endodontically treated teeth with moderate bone loss have a greater fracture rate, probably because the tooth wasn't restored properly and the occlusal schemes were not controlled. So this is why you must do a comprehensive examination to make the right decision.
Our third question, can you use glass ionomers or resin modified glass ionomers to cement posts and do foundational buildups?
Good question. I would say that you stay away from those products. They're weak materials. Bond strengths of glass ionomers are less than 10 megapascals to dentin. Cervical or apical root canal or root dentin, even weaker. You're not going to get a good outcome cementing a crown with glass ionomer or doing a post with a glass ionomer, and especially doing a post or core buildup with a glass ionomer or resin modified glass ionomer. Please stay away from those materials when doing those types of procedures. Use core materials as your go-to. If you want to put a post in with a cement, self-adhesive cement, resin cement, that's fine. But you're still going to need to bond the coronal aspect. So you're doing two different procedures, and you're not creating the true monoblock. Again, the other aspect is whether or not I would want to do an endocrown. But remember, with the endocrown, I can't seal the tooth immediately because I need to access the canal for the endocrown. The only way I would do an endocrown is on a molar tooth, and if I had chairside milling. I would not temporize the tooth and then put the endocrown in after. I might as well do the other procedure, seal the tooth immediately. So stay away from glass ionomers, resin modified glass ionomers. They're too weak to hold post and to do core buildups.
Okay, how do you get the bleeding under control with a pulp exposure prior to placing a core buildup?
Okay, great question. So say on that case I showed you at the end, if I had a pulp exposure, there's two ways to test or test the the pulp as well as get the bleeding under control. What I would take is a cotton pellet of sodium hypochlorite, put it on the exposure for 30 seconds. I'm not pouring it into the tooth. I don't want that to be, as I already showed you. I will take it off in 30 seconds. If the bleeding is controlled, that means the pulp is pretty quiet. If the bleeding continues, then that means I have pretty much a hot tooth, very hemorrhagic tooth. Then I may need to use something else. In that instance, I would use something called aluminum chloride. I use a product called Hemaban from Dentsply, Serona. You could also use other products that are out there that have 25%, made by Ultradent and Premier. All good products. I use this material because it's more of a gel consistency. It doesn't fly all over the dentin. I don't want to get it all over the tooth. I just want to go in exposure. So I'll use, again, a cotton pellet with Hemaban, 25% aluminum chloride. The difference between ferric sulfate, which is also a hemostatic agent, and aluminum chloride is that aluminum chloride will not interfere with bonding. Ferric sulfate will. So those ferric products that are those hemostatic agents that are very dark color, red color, you want to stay away from those types of hemostatic agents when you're doing bonding. So I will, again, get that under control. Again, if the sodium hypochlorite works, then I just cleanse the area with chlorhexidine, 2% chlorhexidine. I like to irrigate the area, decontaminate the area, and then I'm going to take a material, calcium silicate material. It could be, I like a product called Ultra Blend made by, I don't know who makes it, but it's a good product. Or I could use a product called Theracal or Dical, any of the products, just to put it over the canal that was exposed. I don't want to use any bonding agent at this point because it could crystallize in the canal, and then the endodontist would not be able to get down the canal. So I cover any exposure with any of these materials, calcium silicate materials. It's white, it's opaque, they can see it when they go down through the core buildup, and then I'll bond over that. Again, I'm careful not to disrupt that while I'm bonding, and then put the core material, and I'm set. I've sealed the tooth, strengthened the tooth. So if there's any bleeding, cotton pellet of sodium hypochlorite. If that doesn't work for 30 seconds, then go to aluminum chloride 25%, and that should control the bleeding. clean it, irrigate it, get any residue of that aluminum chloride out, and then put the calcium silicate material over the exposure, and that should do the trick.
Right. This person does not do endodontics or chairside milling. The question is, how do I make the root to crown procedure work in my office?
Okay, so I happen to be in the same situation. I don't do endodontics, nor do I do milling in my office at this point. So what I do, particularly in these cases, when a patient comes in with a hot tooth, and I know it's endo, and I'll give you an example. It's Friday, 3:30, 4 o'clock. That's when you get those emergency calls. Patient comes in, my tooth's killing me, it's the weekend, and I know you're not going to be in, can you see me? So many dentists send their patient to the endodontist immediately. I don't think that's the right thing to do. Number one, it's not fair to your endodontist. I know the endodontists are loving me right now for saying that. It's not. So what I'm going to do is I'll say, patient, come in. I'm going to remove the caries, get the tooth stabilized. Again, just following the same procedure. If I had exposure, I just showed you what to do. If I don't have an exposure, I'm bonding and putting the core buildup immediately. Then I'm going to prepare the tooth, take my impression, whether it's conventional scan, and put a provisional on the tooth, and then get them to my endodontist by Monday. If I will call my endodontist and say, I just saved you a visit or trip to your office this afternoon or tomorrow, hopefully, but I need you to see my patient immediately Monday or Tuesday or as soon as if they are symptomatic. In all likelihood, the patient may be a little bit symptomatic, but not excruciatingly symptomatic, only if they had a really, really bad infection in that tooth. So this is a way I'm sort of sealing the tooth, strengthening the tooth, possibly reducing all the sensitivity, all the issues of the tooth, and doing a good deed and getting good kudos from my endodontist. Okay, so patient comes back after the endo, like I showed you the procedure. If I had to drop a post, I'd tell my endodontist to drop a post space. If he doesn't have to, I'll just go in, retrofill the access with the core buildup in the way I showed you, just phosphoric acid, silane, and bonding agent, then fluorocore. Don't fill it up all the way, and then I will cement my crown in. The second visit takes me 20 minutes. 20 minutes. Instead of spacing this out 2, 3, 4, 5 visits, you're doing it in 2 visits for yourself, 1 long visit, 1 short visit, and the endo visit. 3 visits if it's a vital tooth. If it's non-vital, then of course you have to extend the endo. This is the way to do better dentistry. Whether or not you're doing scanning or endo doesn't make a difference. We can still all do the right thing. This is how we're going to impact dentistry. We are placing far too many implants. We need to save teeth. And I hope I've showed you the way to do that.
Wow, what a perfect place to close. Thank you for everyone for your questions, but we have run out of time today. So if we did not get to your question, we will answer it after the webinar via email. Be sure to take the free CE quiz associated with this webinar to receive the continuing education credits associated with this presentation. Shortly, we will send you a recording of this presentation and instructions on how to access the CE quiz. Thank you all again for attending. A special thank you, very much thank you to Dr. Alan Atlas and to our sponsor for this webinar, Carl Zeiss Meditech. Thank you and have a good day.